Welcome, everyone. On behalf of the American Heart Association, the Missouri Department of Health and Senior Services, and Health Quality Innovators, we welcome you to this third session of our Innovations in Hypertension Control mini-series. We are so pleased and thrilled with the engagement and the attendance of our first couple sessions, and we're really excited to end our mini-series with the topic of hypertension and telehealth. We've wonderful to see the momentum of our statewide effort to improve hypertension control. For those of you joining for the first time in this session, my name is Rochelle Bartnick. I'm the Senior Director of Community Impact for the American Heart Association serving Missouri. And I want to thank you for contributing to our statewide efforts around the same goal of marching towards that hypertension control rate of 70% or better. We know we do this one patient at a time. So I'd like to introduce one of our collaborators, Chris Hummerfield, to offer a few words. Chris?
Thank you very much, Rochelle, and thank you all for attending the Lunch and Learn today. May has been Hypertension Education Month and is recognized by CDC and the National Heart, Lung, and Blood Institute. This virtual workshop series is a collaboration, as Rochelle explained, of the American Heart Association, Health Quality Innovators, which is the Missouri QIO, and the Missouri Department of Health and Senior Services. These three are partners of the Missouri Million Hearts Partnership. And of course, there are many ways to lower blood pressure, but we were highlighting three of the more promising innovations in hypertension control. Each of these programs in the mini-series have placed an emphasis on improving the quality of hypertension care for patients. Thank you all for attending this session today. Rochelle, I'll turn this back over to you.
Wonderful, thank you, Chris. And I'd also like to highlight Mary Ann Kimball with Health Quality Innovation Network. She's also been a contributor to this series, and she'll be joining us to moderate the Q&A a little bit later. So we want to remind everyone just quickly a best way to kind of enhance your Zoom experience. You certainly have control over the view, and there on the screen, I'm going to remind you of some of those tips to maximize your viewing options. You may need to exit full screen, and then make sure you set have the setting to gallery view and side-by-side mode. And so, also keep in mind there is a slide bar in the middle of the screen to determine your viewing preference. So click the slider bar and drag to the left or the right to adjust to see the content. We also will have the opportunity to do Q&A towards the end. So be sure to maximize or go ahead and make the change in the chat box now to all panelists and attendees so that you're ready to go when a question comes up. We also will have the opportunity for you to raise your hand should you want to be unmuted and ask your question to our presenters. So with that, I'm very excited today to welcome some leaders in this space of telehealth and hypertension control. We are excited to have Ingenium Digital Health Advisors lead us through a presentation on this topic. I'd first like to introduce Christian Milaster. He optimizes telehealth services for health systems and physician practices. He serves as a digital health and telehealth advisor to startups and established digital health companies. Christian is a master builder of digital health and telehealth programs and the founder and president of Ingenium Digital Health Advisors, which is a boutique consultancy focused on enabling the effective delivery of extraordinary care through workflow optimization and the judicious use of technology. He was born and raised and educated as an engineer in Germany and started his career at IBM Global Services before joining the Mayo Clinic in Minnesota, where he worked for 12 years in various roles before launching Ingenium in 2012. Now he will be joined by Dr. Matt Faiman, and he serves as a staff physician at Cleveland Clinic Foundation in Cleveland, Ohio. He received his master's degree in business administration and medical doctorate from the University of Manitoba in Winnipeg, Manitoba, Canada. He completed his residency in internal medicine at Cleveland Clinic in 2002. In 2005, he became involved in telehealth, developing innovative ways to apply telemedicine programs at Cleveland Clinic. And in 2015, he was appointed the medical director of Express Care Online, a service line providing on-demand synchronous virtual visits to patients nationwide. Dr. Faiman is passionate about finding innovative ways to apply telehealth both nationally and internationally. We are so pleased to have them as experts here today. And Christian, I will turn it over to you. Thank you again for being here.
Thank you so very much for having us here. Let me start my screen sharing here, bring this up. Very glad to be here. I'm great to see the big interest here. We've got a high number of attendees. That's really wonderful. Buried in my very nice bio that Rachel that created here for us was that the key statement that really drives me, and that's to enable the delivery of extraordinary care. That's what I've centered my consulting practice around. That's what I learned at the Mayo Clinic. I spent 12 years at the Mayo Clinic where the needs of the patients come first. And so that's really where I got my introduction to healthcare. And I've taken this now into my consulting practice. Also extremely delighted to be joined here by my colleague and friend, Dr. Matt Faiman here. We'll be dividing up the presentation here a little bit. I'll give a little bit of introduction. Dr. Faiman will then jump into the subject matter area of hypertension management with telehealth and remote patient monitoring. We'll have a Q&A at about 12:35 Central here, and then we'll wrap things up. I'll give you some very specific guidance as to how you can optimize telehealth in your organizations. What are some of the principles? So very glad to be here, very glad to contribute and share the knowledge of what we have learned here over the years. Dr. Faiman since 2005, me since 2000, around 3 or 2008, depending on where you put it. So without further ado, let's jump into the subject matter here. And we'll start with some definitions, because what I learned, what Dr. Faiman and I share is that we've been working at academic medical centers. And after way too many committee meetings, I learned that everybody agreed until somebody defined it. So let's start with some definitions here on this section. Telehealth, the term, I just use the simple description of delivering care at a distance. That's really what it is about. And it involves anything where the patients interact with clinicians. Telemedicine then specifically is the interactions between clinicians and patients. Could be synchronously, like in a video visit, could be asynchronously by reading or reviewing the history of blood pressure readings. So If you do put this visually into a taxonomy, you get telehealth as the overarching umbrella term that breaks down into telemedicine, but then also into like teleeducation and patient portals. So requesting immunization records, booking your next appointment, exchanging notes with a physician. From a patient's perspective, that's all receiving care at a distance. And so it really should be part in the purview from a patient's perspective of your telehealth services and offerings. And then telemedicine breaks down into interactive patient care. So that could be video. In the future, I think we'll see much more synchronous texting or kind of semi-live texting with the secure messaging going back and forth, remote patient monitoring, not just blood pressure, but continuous heart rhythm monitoring or fetal EKG stress monitoring. So there's different ways. And then store and forward. So faxing an EKG is telemedicine, and it has been practiced for ever since the fax was invented or introduced to healthcare. And healthcare is not letting go of the fax. So the last fax machine will be at a hospital somewhere in a rural county, somewhere in the world. So. And we're doing all of this to achieve the quadruple aim, right? We want improved patient satisfaction. We want to have better health outcomes, which is specifically the topic here for today, and ultimately bend the cost curve. We want a lower cost of care. We want to prevent patients being admitted, patients getting out of line of the parameters where the care plan has been managed, and how can we make it easy to engage the patients. And that's why I love to use the quadruple aim, not just the triple aim, is we need to optimize this for the satisfaction of the providers as well. The solutions need to be easy to use. The technology needs to be fade into the background very quickly so that physicians can do what physicians do best, and that's to listen to the patients, devise care plan, make decisions, and help them to make, oftentimes with blood pressure, the lifestyle changes that are needed. And the physician as a trusted partner plays a key role in that. We have a very different environment than probably even when Dr. Faiman started his journey in healthcare. Back 20 years, 30 years ago, we were patients that were not cowering, but we are respecting the white coat expertise. And now everybody comes into the physician practice armed with Dr. Google printouts, with knowledge about what disease afflicts them and what treatment is the best. And then add to that we're having a lot of out-of-pocket payments, high deductible plans. And so quality and confidence is what always people were looking for in the past. And that's where academic medical centers sit. But now we really want value because we have to pay a lot for our healthcare with our own dollars. And these days we want convenience. I mean, if I can order an Uber, if I can arrange for an Airbnb, I can order Amazon, I can have something shipped overnight or even the same day. I want that same experience from my healthcare provider. And so what that kind of is really that the sweet spot for any organization lies there. And that's where hypertension management comes in. How can we do hypertension management that is high quality, that gives you the confidence that the latest protocols are applied, but it's convenient so that it is sustainable, meaning that patients will stay and stick in their care plan. And how can we make this free, ideally, or being paid for by the insurance that you may already have? So that's really the sweet spot, how we can serve the modern healthcare consumer. And with that, we're going to do the switch here from the screen sharing to Dr. Faiman. Just give us a second here, Dr. Faiman, to start his sharing. And there we go. And
okay,
Matt,
so
yours.
let me make sure everyone can see and hear me okay?
Yes.
Okay,
good.
Great. I just want to make sure that I can. One of the things that Christian and I have talked about is this website manner, and of course here I am working this Zoom, and I'm trying my best to respect. I'm going to have to deal with this one way or the other. Is that we all have to suffer with technology, regardless of the things that we do, and. Here I am with multiple screens, and one of the things, this is going to be unrelated to this presentation, but just a nugget that I share with clinicians when I'm training them, doing this a while. When you work with two screens and you have to move your head back and forth, you have a tendency to shake your head and it looks like you're saying no, and patients are consumers, and they realize that you must be very upset with something that they're doing, especially the behavior, especially when you're doing this. But regardless, I'm going to have to do this because My screen is over on my right, so I'm going to do my best to have memorized everything that I'm going to talk about and work my best. So my job today is to speak about the sort of clinical application of telehealth and hypertension. And as a practicing internist for the last 20 years at Cleveland Clinic, and as a practicing tele-internist for the last 15 plus, it's sort of one of the passions of mine of merging the two, and how best we can utilize some of the tools that we have and some of the clinical things that we have to deal with on a day-to-day basis in chronic disease management to marry those things together. And so, and whether the fact I trained in Canada and we have more of a single payer system up there, and moving down to the US where, obviously it's sometimes a wild west, a free for all, but with multiple payers, at the end of the day, chronic disease is chronic disease, and it always helps to level set. And this is sort of where I'm coming from with like thinking about a disease, identifying it, putting it in terms we can all recognize. And obviously in the theme of the month of May, we're obviously in June now, but knowing that, if we can identify what hypertension is, then we can frame how to best maybe handle some of this. And so I think level setting, we all know that hypertension is a moving target. And as I put these slides together, I had to double check that they're probably out of date in some ways, even as I put them in there, because the American Heart Association, the CDC, the World Health Organization, and those who write guidelines know that we may be moving the target lower and lower. All the same, I think, there can be some disagreement about what is normal for blood pressure from when I was a resident 20 years ago to now, but this helps. And so knowing that, normal blood pressure now may be defined less than 120 and less than 80. Elevated blood pressure now is 120 to 129 and less than 80. And then thinking about where a hypertensive crisis may be defined higher than 180 and higher than 110, where protocols have been set up. Ironically, my brother-in-law works in the emergency room, and I don't know how many referrals he gets for patients sent in because they call my office and they're told go into the ED because their blood pressure is high, but they have no symptoms. So we're going to take some of these pieces and kind of put them into practice, because at the end of the day, these are data points, and we can't just think about patients as data points when we're using remote physiological monitoring, but we have to put that into perspective, because how we manage this now and in the future is going to really make a difference in terms of what we do about managing these issues better, because patients really are going to not want to sit in the emergency room for 4 hours to be told, well, take an extra of your pills and go home and call Dr. Faiman in the morning. Like that's not going to work very well. And patient satisfaction is just not going to be where we want it to be. So who has hypertension? Well, surprisingly, a lot more than we think. And this is a little out of date CDC data from 2018, but nearly 45% of the US population has hypertension, defined with BP greater than 130/80. That's not great. And only a quarter have controlled hypertension, not particularly stellar. And hypertension really, in my mind, from when I was a resident to now, shifted, in terms of, this is the problem in so many ways that leads to the cause for heart disease, the cause for, neurovascular disease and stroke and chronic kidney disease. And we're trying our best now to get patients to understand it's often and most often asymptomatic. Patients aren't going to feel these numbers, and yet this is what's going to get them into trouble. Looking at this another way, and I think this helps, and I'm not going to quiz anyone later, although you can quiz me. I look at, when we start to recommend interventions for patients, particularly around lifestyle, I think there's a good number that are going to do well with lifestyle, 20%. Though ironically, maybe not as many who come in the office and say, doc, give me 3 months, give me another 6 weeks, give me 6 months. I'm now, I'm eating clean and I'm doing yoga and I'm meditating and I'm doing all these things. I think that's extremely important, but sometimes patients really are going to have to recognize that their blood pressure is going to really need medication. And that may be the vast majority. The other side of this is that, how many in the adult population in the US have controlled blood pressure? 23.9 million. 26% of the population. Like, we have a huge number. Thinking about when we leave today's discussion and you try and think about that one patient you want to get to goal. And I think any more patients that we can get to goal is going to be fantastic. But we also are going to hear from Christian about how can we think about scaling some of these programs, because from a reimbursement side and from how we can get this on a population health scale, there's a lot of patients here that we really have to tackle, and that's where some of this is going to come into play. So I think I've learned enough about this, and I'm going to share a hypertension 1.0 trial we had. But delivering care in remote patient monitoring is not just about the data. It's really more about how you leverage all of those other pieces that clinical studies now that have been published in numerous peer-reviewed journals have shown, that not just monitoring data gets the patients to goal. And why is that? A couple of studies showed that if you had patients self-monitor and make adjustments for a brief period, 4 weeks, 8 weeks, they get their blood pressure down. But for example, if you don't do behavioral modification or motivational interviewing or discussions around SALT, essentially 6-8 weeks after that, the blood pressure tends to go back up. And particularly if you don't communicate within the team, and particularly within the primary care team, if you exclude them out of this equation, numerous studies show that the blood pressure ultimately doesn't get managed, because you're not keeping this within the whole interdisciplinary team. So you have to kind of consider that there's going to be a whole approach, a holistic approach, when you manage remote monitoring beyond just data. So a good article around this just got published last month, and I think we can all learn from this that CMS has been reimbursing more recently and sort of expanded it, and COVID sort of accelerated this around the monitoring of the blood pressure. Now has been reimbursable to providers. If you monitor data per month, if you enroll patients, you can get tech fees and professional fees. And this is good. I mean, this is motivating academic medical centers and, chief financial officers and all sorts of people, the people I have to report to justify giving our patients these expensive devices. And quite honestly, they're not that expensive anymore. We all can go to Amazon or other places and get them. But I think the new models are talking about, if you are in accountable care organizations or part of one, or if you're being reimbursed in upside downside risk models, which we are now, we have to think more strategically around how these models, especially from the payers, can be used with us offering them cost reductions, unnecessary ED utilizations, unnecessary readmissions, by enrolling patients at the outset with full programs. And that's what this article points to. And I think it's really interesting and worth a read. And we'll be sharing these slides with you, so feel free. So backing up to where I said before, Cleveland Clinic has all these what I call one-offs. And it's like the Me Too's. Everyone in every department feels like, I'm excited. I want to get involved in my clinical study to do remote monitoring. Why? Because unfortunately in the tech world, the devices sometimes are far ahead of the science. And so like you can see here, there's fancy schmancy scales and thermometers and blood glucose monitors and Bluetooth enabled blood pressures, and even devices that you can put on your meter dose inhalers for patients that will tell you, hey, Johnny, who has asthma, my son, didn't take his inhaler today at 9 a.m. like he was supposed to, and I can get an app that tells me when he didn't deploy the inhaler. Now this sounds great, but if you can't put it into a usable format to know that it's allergy season and his asthma gets exacerbated, you're not going to really put it into some kind of practice. So thinking about this in terms of hypertension, we decided as a group in primary care, I asked many of our primary care doctors if they were interested in monitoring their patients in hypertension, and all the hands went up, hundreds went up. And we have 800 primary care doctors in our institute, but we couldn't get everyone involved. So we grabbed 10 providers and said, we are going to do a case control study. We're going to take patients of yours that are in your usual practice, and we're going to also enroll about 8 to 10 per provider. and we're going to match them, and we're going to watch them over the next 6 months. We're going to give them usual care, your usual care in your office, but we're also going to enroll them with all these devices, particularly blood pressure cuffs and scales and all the devices that we need. And we're going to do an intense monitoring, behavior modification, coaching, and if necessary, and they have symptoms like I started a new medication, I'm having a cough from this ACE inhibitor, or I'm having swelling from this calcium channel blocker, then we could triage their symptoms using our on-demand service with nurse practitioners. We could do all the necessary parts. And so we compared ourselves using our Cleveland Clinic Care Path for Hypertension. Telehealth, as we know, is a modality to deliver care at a distance. And we recognize that we would follow our own care path that we would do in person. It's the same way of delivering care. So we offered that. We enrolled pharmacists, we enrolled the patient, we used a full analytics, and we used our EMR to feed the data right in. And we had all sorts of touch points for the patient, and we delivered them at minimum about 5 or 6 behavioral modification sessions. And the patients got enrolled. We had 80 patients, and really what we at the primary outcome was, could we obviously improve blood pressure? And we did. After all these touch points and after getting coaching, we reduced blood pressure 7.4 on the top systolic and 3.1 on the bottom. Now, when you look at studies that even for new blood pressure medicines or studies like the HOPE study and others, they had much lower readings of reductions in systolic and diastolic. So we were quite pleased that after 6 months that we could do this. Even more so, and I'll read some of these testimonials, we had lowering of LDL cholesterol, reductions in hemoglobin A1C, improvements in depression scores, because we monitored all these. But we also had patients who felt far more engaged to the program. It's been helpful. It's increased my awareness and it's had me become more accountable. Thank you for my email and my new prescription. I do believe that you're getting me in this study has saved my life. Quite honestly, there were a few thanks like that we were surprised to hear, because the program made the patient feel so much more connected. And that's what we really took away as messages for this. And so patients really felt enhanced accountability. Anecdotally, I have patients of mine, this is from 5 years ago, who still are following this 4 years ago. And they still have the tools that they're using, and they're still, I have at least I can think of 5 of my patients who still have their blood pressure at goal. So I'm a numbers guy. I know Christian's a numbers guy. So looking at it in stark numbers, at the time in primary care, we had over 16,000 patients that we were trying to get to goal in 2016, which was around 52,000 patients. We knew we weren't necessarily going to get there. What happened at the end of 2016, in usual care, brick and mortar care, only 15.5% actually got to goal. At the time, it was 140/90. In our cohort, we achieved 62.5% at goal at the end of 6 months. So that really resulted comparatively of a 300% improvement in blood pressure control. I mean, I was amazed at what we saw, and our leadership was really amazed at what we saw. So I think this points to how current programs using pushes and pulls and the ones that we have been using to date are working, but they probably could work better. So how can they work better? Well, one thing that we're starting to use, and I think this is the sort of future of telehealth, is that there are maybe not as much utilization yet of artificial and augmented intelligence, but there really can be and there should be. And though, we all have these smartphones, mine's sitting, up here around, and we get notifications and we get pushes all the time, but we need to probably figure out ways to utilize them better to make behavior modifications. But we need to think about models of care that could enhance how we optimize and scale. And though this is a busy slide and I'm not designing this to be too complicated, I just want to point out that our team has sort of, stepped back briefly and in order to move forward. And what we did is that we looked at over 80 to 85 variables of patients within our EMR, including things like readmissions in the last 30 days and 60 days and 90 days, as well as Charlson risk scores, which is, what is your chance of being admitted to the hospital? Comorbidity risks, like do you have heart disease? Have you had a stent? Do you have chronic kidney disease? Do you have diabetes? Do you have those kind of risks, as well as social determinants of health, literacy, access to food deserts, and we put them into sort of a stew, because we realized after doing a significant literature review, there really aren't that many risk models out there, and using fancy statistics, which our statisticians are very proud of, and this is well above my pay grade, and I'm a stats major, and even so, we realized that you can utilize these to probably do two things. One, when you see a patient in your office, you can determine, Mrs. Jones, who's seeing me today, who has hypertension, with her risk panel, I can actually give her this medicine, even though the standard of care says I can choose from these top 3-4 medicines. This one's probably the best one for her at this time based on her risk. That will help. The other thing is scaling. If you have 100 or 10,000 patients that you're monitoring and you get alerts, your team gets 1,000 alerts or 100 alerts because all these patients ring at 180 over 110 that morning. How do you triage all those patients with the personnel in your health system? You have to figure out how to figure out alert-wise what's important, who's important. Did someone go to a rib cook-off that weekend and have too much salt, or is someone legitimately at risk to be admitted that day? And using risk models, that will help you define who needs to be triaged, who's in a red category, and who's maybe in a yellow or maybe a green yellow. And that will help you come up with maybe categories like this as you move forward. And this is sort of my own idea. I'm going to hand this back to Christian in just a minute. But as I think about, as we move this into direct to employer and within our health systems, that there are probably ways to have programs that are developed and enroll patients and our own employees right from the get-go, because we see interest all the time. Taking sort of an approach of, you have those general wellness, that 20% who can do lifestyle and are interested and may not even have hypertension yet, but maybe on the road, and give them a low touches, a little bit of pushes and pulls. But then as those patients may get pre-hypertension, we can do a more moderate approach, light the fire under their, behind and get them going. And then as we move into those who have higher risk and the cohorts with uncontrolled, we really intensify the options and enroll them and do that approach that includes motivational interviewing, coaching, and specific sessions, because if we can then reduce the cost, readmission, ED utilization, and burden on the system, then we save way on the back end. And obviously, there are a percentage, 10 to 20% of patients who have resistant hypertension, and there's nothing we can do about it. They need referral to specialty nephrology, cardiovascular medicine, who have specialty. Those are the ones who are on 3 medicines, and despite that, their blood pressure is not at goal. They need assessment for secondary causes of hypertension, etc., because then they need not only the usual care, but they need a much more intensive approach. And I think that a possible future with artificial intelligence and scale and remote devices is going to be a way, especially when patients don't want to spend time in the office all the time, will allow us to get our patients much better control and marry kind of chronic disease management with remote monitoring. I know I jibber jabbered a whole bunch there. I had a lot to say, but I wanted to respect, the time and the audience. And I know that there may be queries, and I'm going to turn this back over to, a brief pause before Christian gives some additional thoughts about deployment. And then we'll go over to some Q&A, etc. Thank you.
Thank you so much, Dr. Faiman. Hi, everyone. This is Marianne Kimball, and I'm with Health Quality Innovators, and I will be facilitating the Q&A portion of today's event. So if you would like to ask a question at this time, please use the chat function to enter your question, or if you would like to ask a question verbally, use the raise your hand icon and we can take you off of mute. And we do have some questions and some comments. So hold on just a second. Okay, so Dr. Faiman, can you define pushes and pulls? That was
yes,
on one
sure.
of the slides.
So Yeah, pushes and pulls. So we all, a push notification is that, you know, you have something in your email or something that you need to do, like an activity, like please fill out this questionnaire, or please send us information, or please do this activity for us. A poll might be, we need to see you in the office, or we need to speak to you today. There's more information. We're pulling people towards our health system to get them access into the system. Where we might do minor pushes, you know, we all may know what a push notification is. Those would be kind of the minor things. Pulling people into doing things would be sort of the pull side of the world. Like we want them to, you know, eat their fruits and vegetables and follow the Mediterranean diet. Those are pulls are harder than pushes. That's kind of the way I would look at it. If Christian wants to add more, by all means.
Okay, and then we have the next question is, let's see. Someone would like to know why
Yeah.
you are
Using outdated hypertension
Yeah,
guidelines.
hypertension guidelines.
Yeah, well, you know, I wanted to respect that the guidelines. I'm using the 130/80, not the 140/90, and the only reason I'm using the mix is not because I wanted to confuse the issue. Is I knew I had to present our data, which came from the 140/90, which was going to probably create confusion unto itself. And I know that, you know, AHA and others have, you know, we have the newest guidelines. I went just to sources to try and just frame a discussion only around that. Even with old guidelines, there are many, many millions. It wasn't meant as a slight to anyone on that. And so I apologize for not being as to the date as I could.
Okay, thank you. The next question is, were patients enrolled in your study selected randomly? And are those patients that agree to enroll more likely to be engaged in care and motivated to improve hypertension control?
Yeah, great question. So they were, we took patients with similar, like I mentioned, Charleston scores, comorbidities and risks, and we actually went PCP by PCP, and we then did as much a case control as we could per PCP. So in my case, I had like 150 patients that were selected based on these risk profile. We tried to randomize them as much as we could, like this would get usual care, and this patient, next patient would be enrolled in the study. Then we had to go through the enrollment and see if the patient wanted to be enrolled in the study, knowing that they would have to get a Bluetooth cuff. Were they technically capable to be using the cuff? And some decline. That's why we had some declined patients. But it was as much as we could match the risk, and then we enrolled them as much as we could in a randomized way, knowing that then we had to go through the process of calling them up, seeing if they were interested, and then if they said no, we'd have to then go down the list. So in some ways it was as randomized. It wasn't blinded, but it was as randomized as we could make it. And then are patients that agree to enroll more likely to be engaged? So hard question to answer, and good point. Possibly, although knowing from my own personal, you know, patient panel that I selected from and seeing who actually chose to do it, I was shocked at who decided to do it. I mean, I had a couple of people who I said, yeah, they were definitely going to do it. But then I had ones who I had no expectation. They had been uncontrolled for 15 years, and then they opted to do this, and they suddenly became controlled. So my own expectation, plus they were ones that I said, they're never going to get the technology down and do everything incorrectly. And they're going to use like multiple cuffs. The cuff we give them, plus they're not going to believe it. So they're going to use their home cuff, and then they're going to use their children's cuff, and we're going to have a big mess under our hands. They seem to follow it. So I was pleasantly surprised that there was mixed motivation and engagement, even just with self-selection. So obviously the selection bias being a problem always, I was, you know, pleasantly surprised.
Okay, thank you. Can you speak to how a practice might find undiagnosed hypertension?
Find it. I'm not sure but besides the measuring it, I'm not sure how else to, if I'm not sure I understand exactly how to answer that, or maybe I just don't quite understand the question.
Okay, maybe we can
We can
just
circle back.
ask them to repose that question.
Yes, sorry.
Okay, that's okay. So the next one is, the next comment is outstanding work, Dr. Faiman. Has your Cleveland Clinic study been published and can it be used as a model?
Right, so our hypertension 1.0 was published. We presented at a couple of meetings at the American Telemedicine Association and a search meeting, which was more of a clinical meeting. And the model itself using the risk score is unfortunately still in its like evolution phase. So as much as I'm hyping that it's like been in practice and we're all excited because it's there, we still are working out on the kinks. So the first model is there. It's, you know, and it's something that the operational pieces was, you know, described and reported on. The other piece is my sort of wish list of how I would like to see hypertension managed in the future.
Okay, thank you. And could we go ahead and unmute Sarah Eve Sarliker?
Hi, thank you. I have two questions. One is more of a comment. So we're working with a federally qualified health center in northern central Washington, right near the border with Canada. And they are finding that using team-based care and their medical assistants and community health workers in their kind of moderate risk patients, so not their highest risk because they don't want to have working with a nurse, but their other patients. And again, I think they're finding surprisingly good outcomes with that. So just in terms of, I think they're starting to stratify risk a little bit, but maybe retrospectively. But are there any tools that are available right now that might help with that kind of stratification for other practices? That's my first question. And my second question is, one thing we've uncovered both with them and really with everyone else is this multi-payer setting we're in, that it's really demotivating for these kinds of programs when they have to match, like, okay, this monitor with this patient with this. So they are really pushing for there to be no prior authorizations, just the easiest possible, least red tape possible for patients to get matched up with monitors. They're willing to provide kind of everything else in terms of the staffing and the training and all of that. And it's just the monitors, which they know are not very expensive, but when they're rolling this out to 100 patients, and I think some of them need those extra large cuffs, it can get expensive, especially for health centers.
So great observations, and we too have seen some excellent work with our partners in Canada, and you know, not to hype up Canada, where I grew up and trained. The risk stratification, there are actually a few models that are sort of off the shelf that can be used, and I'm going to try. I can hopefully get to the group by the, you know, at least we can share some locations or sources. Just like there are, you know, Optum and others had created like inpatient risk stratification models for readmission risk. There are a few out there that can be like, that are sort of like semi-generic that can be used operationally for putting into play. They're almost akin to, like, if people are familiar with Schmidt-Thompson, the two doctors who created a pediatric and adult triage tools for symptoms that are used for after hours or daytime triage for people who have like chest pain and shortness of breath, and of how to manage those. There are a few that are in existence, but that's been the challenge. There really aren't the stratification things out there that are deployable. I think that what's trying to come to market is building with that and some AI to come up with something that others could use to figure out those medium risk people and build that in there. So there may be a couple of things I can point you to. Regarding the payers, like the one thing that was often a barrier, and it's an operational hurdle, is like figuring out from a system approach, one device, how you get it to your patient, how you train your patient, what kind of video you use to get them onboarded and synced the data so it comes into the EMR in an easy way, and that you can incorporate it directly in such a usable format. Like those are as much of a challenge as the how I'm going to get reimbursed and what system we're going to use, because that to me has been as much of a stumbling block. And so what we at Advisor, I at least have recommended, was using one device only, that the payer decided, okay, that device has been approved by either AHA or by, there's 2 or 3 sites nationally and internationally that have approved Bluetooth enabled blood pressure cuffs, several from A&D and from Omron and others that are approved. And then you pick one, and just pick one and not multiple, because it becomes too difficult to train patients and to get it synced into your system. But I agree that is as much a barrier, especially with payers, as anything else. And I think those are where advocacy and having groups that can step in to try and push, especially now as we're trying to get some changes at the federal level to help get some of these changes made, to make it easier across the board, because these are as much the challenges around getting more devices into patients' hands at an easier rate. That's just my observation.
Thank you.
Okay, and I do not see any other questions at this time, so I will turn it back over to Christian.
You're muted, Christian.
I'm muted. So yes, thank you very much. Great questions. Let me just rearrange my screens here. Something got blocked. I cannot access Wonders of technology. Zoom is very particular about where it wants to place its windows versus where I want to place my windows. So great. One thing that I wanted to highlight here, and that was on the last slide that Dr. Faiman shared here, is, and it came up in the question that Sarah Eve just asked, is really about that it takes a multidisciplinary approach. I mean, we cannot solve those challenges with just one technology or a Bluetooth connected blood pressure cuff. It takes the involvement of primary care, it takes especially the coaching, some predictability with AI. So I think that's maybe where the question was going with regards to how can you anticipate the diagnosis of hypertension just based on some other metrics that have been collected. Obviously, if a patient does not come in, then it's very hard to diagnose hypertension there. So great. So we'll move forward here. So now that we have all this knowledge and we want to do telehealth and telemedicine, and you're also welcome to request your white paper that we've put together around just the basics of remote patient monitoring, not specific to hypertension. You can just send me an email. How do you now implement it? How do you optimize telehealth? A lot of organizations over the last 12 months have launched telehealth, telemedicine, especially the interactive video visits. Some have resorted back to telephonic visits. Now that reimbursement for that is going away, people are evaluating how they can integrate video-based telemedicine. And then also now, how can we take advantage of remote patient monitoring to monitor some of those vital signs and congestive heart failure, CVD, all the other comorbidities that sometimes are alongside hypertension. So Albert Einstein said insanity is doing the same thing over and again and expecting different results. So I want to offer a few different approaches here on how you can optimize and leverage telehealth and telemedicine. So I want to just highlight 3 different strategies here. One is a conscious focus on growing the maturity of telehealth in your organization. The second aspect is to start measuring the performance of your telehealth and telemedicine systems. So I'm going to offer, or telehealth services, I'm going to offer some aspects here. Obviously, we want to measure outcomes like Dr. Faiman did in this study around blood pressure. But since remote patient monitoring and telehealth is such a new technology where we can deliver care through we need to also measure the performance of that with regards to satisfaction and problems and volume and reimbursement and all of that. And so I'll talk about that, give some pragmatic guidance. And then the last and very important thing is change management. And if we still have time, I'm going to maybe ask Matt another question about, it was great to hear that the hands went up of the hundreds of clinicians and you could only use a few. But then there's a difference also between interest and then actually changing the way that you practice medicine for the last 20 years. So maybe you have some insights to that as well when we get to the topic here of change management. So good. First one here, maturity growth. Really, the idea is everybody got thrown into telehealth, telemedicine, probably the utilization and the confidence and the comfort with telehealth and telemedicine is at the early beginning stages. And so what I suggest here that that the leadership and within the organizations really create a clear vision as to where do you want to take telehealth and telemedicine and what is your current maturity level. And I'll introduce a model here on the next page. What is the desired maturity that you want to reach by when? And then you just lay out a clear path. It's a gap analysis known out of continuous improvement, and then you close the gap. So here's the model that we've developed a few years back. And really it starts with organizations being thrown in. It's chaotic, it's emerging. People are using telehealth and telemedicine all over the place. Then it starts getting a little bit more coordinated. There's a telehealth coordinator, maybe there's a standard set of technologies. And eventually it'll get supported, not just from a technical perspective, but also from an operational perspective. And the kind of the base, one of the home bases where we're aiming for here is to be at that integrated level, meaning that every specialty, behavioral health or dentistry or primary care or urgent care, pediatrics will have access to that, cardiovascular. Everybody has access to telehealth and telemedicine, meaning interactive patient care, with video or with remote patient monitoring. So that's that integrated level where really a lot of organizations are moving toward. And some organizations who started in telehealth before COVID-19 have really accelerated in reaching that integrated level. Because that integrated level really opens the door to the next two levels, which we defined as strategic and transformative. Strategic means that you now look as from an institutional leadership perspective, how can you leverage telehealth and telemedicine to achieve your strategic or organizational goals? Dr. Faiman mentioned that the Cleveland Clinic is involved in upside and downside risk contracts. So obviously there from a strategy perspective, you want to meet those numbers, you want to lower the cost because now you're at risk. So obviously that telehealth is a viable tool to do exactly that. And it's beautiful once we move away from fee for service, because then as a clinician, you don't have to worry about, am I going to get paid for this video visit or not? Did I have a video visit in the last 24 hours and 30 seconds or not, right? So what are the rules around reimbursement? Typically in larger organizations like the academic medical centers, physicians are shielded from those decision makings, but the CFO gives you a call afterwards and say, well, you got to stop calling these patients within a certain period of time because we're not getting reimbursed for that visit. And so we just did an assessment with a rural mental health a clinic or community health center, a mental health center in rural Vermont, and that's where they were at here in April, and now we're moving them towards that, because that's what the CEO said. He said, I want to have this fully integrated into all our 40 different programs that we're offering. Everybody should have access to telehealth and telemedicine. And I want to dip our toe into how can we really leverage telehealth in 2022 and beyond strategically. So he set that vision, he set that forward, and now we've identified that gap. And so that's what that looked like. In the interest of time, again, I'm going to flash it here. You can review it later. But what I have here on the left side are 10 different dimensions of how we're assessing maturity with regards to technical and operational support, and how is leadership involved, what's the vitality. And then we did an assessment. Where is this organization at? And that's the red lines here. And then the target was to be at level 4, dipping into level 5. And then we just sat down and said, okay, what's realistic? Where do we want to go based on where we're at already? And then for each of those 10 line items here, we identified 2, 3, 4 action items that we're now putting into place. So a very powerful way how to really systematize, to optimize telehealth and telemedicine at your organization. So that's the first technique that you can apply, and that will then get you to where you want to be. The second one is performance management. Very few organizations actually have a telehealth services dashboard. Some of our clients that we work with have established that over the last year, really looking at what are our key performance indicators. How do we assess success in telehealth and telemedicine? What are the goals? What do we want to reach? Do we want to have 100 visits? Do we want to have 18%, 36%? What is the percentage of telehealth visits that we are aiming for, or that is good or bad? And just having these conversations can open up a lot of thinking and innovation. Then you measure the performance, and then you improve the performance. And so here is our guidance as to the 5 most critical telehealth metrics. Obviously, there's visit volumes and reimbursement. Those are the low-hanging fruits. Those are things you can get at. But especially reimbursement, I urge every organization to pay particular attention to, because if you're doing telephonic care predominantly, because your physicians still are not really comfortable with telehealth and telemedicine, then you want to do that. Same with remote patient monitoring. There's a lot of codes out there, a lot of states, Medicaid programs. I live in Maryland. Maryland has reimbursement for remote patient monitoring. Medicare, as Dr. Faiman mentioned, started paying for those the different fees. And so do you get reimbursed for the care that you're delivering? Very important, and very few organizations do this well, is to assess periodically clinician satisfaction and patient satisfaction, because this is really where you learn a lot about what are the bottlenecks here, what are the problems, what are the challenges with it. And then you want to also assess technical performance. Telehealth is not about technology, it's a clinical service, except when it is, when the connectivity is not there, when the patients don't know how to use the technology, and there's workarounds, there's improvements that we can have here. You want to have, again, you can review this in the handouts that will be shared with you, along with the recording as well. You can review this later, but you need to define it, you need to identify an owner, you need to set goals and targets, and then you need to have predefined actions. Like, if we're missing the target, what are we going to do? And you can think about that before you even start collecting the data. And so that's how you measure telehealth success. The third area then is that organizational change management that I mentioned. Is how can we help an organization to really implement that change and make it stick, make it sustainable? How do we overcome resistance? How do we create that motivation? And also acknowledge the struggles that are occurring. And the mindset here needs to be in optimizing systems, not people. People will not change behavior unless they want to change their own behavior. But what you can change from a leadership perspective is the environment. And so the model that I have used on all engagements is the ADKAR model from the Prosci Institute, and that stands for raising the awareness, creating the desire, supplying the knowledge, giving them the ability, training on the ability, and then offering reinforcement. What I love about this model is that it becomes very obvious if one of those 5 elements is missing, what's going to happen. If people don't have the awareness of why there suddenly is this RPM protocol, then there'll be confusion. If they don't have the desire, they will resist doing it. If they don't see the value in it, if they don't believe in it, if they don't have the knowledge about, well, where do I order it, and how do I give this to my patients, and who do I contact, right? If they are not really properly trained on how to access this RPM program that you may be rolling out for hypertension management, then there's going to be reluctance. And if they don't have the ability to maybe then download the data, look at the data, act on the data, see how they can access it through the EMR, then they will be frustrated because they know the data is out there and they can't get to it, and they can't read it, and it doesn't make sense, and they can't import it into the EHR, and then they'll abandon it as well. So you really have to have all these 4 elements in place. And then reinforcement, the accountability, that performance measurement that I mentioned before, that's gonna make it sustainable, and so that there's no backsliding. So, and we're coming up here on the end. So just wanted to share here just some more pragmatic guidance as to how you can actually use these 3 principles to implement a remote patient monitoring organization in your organization. You need to definitely have clinical leadership involved here, that it's a clinical outcome-driven effort, but you also need to apply the good kind of systems engineering and process metrics that I've outlined here. So With that, we thank you very much for the invitation here to speak to this audience. I'm glad to see so much interest. We're available for follow-up questions here via email or connect with me on LinkedIn. I also have some white paper and articles available on the 3 topics that I mentioned on the previous slide. And with that, Matt, thank you so much for joining me here. Great. I was going to start with a bad joke, like an engineer and a physician work into a bar, or a German engineer and a Canadian physician work into a bar, but then I couldn't finish the punchline. So thank you very much, Chris and Rachel, and for having us here and making this a great experience.
Wonderful, thank you. And let me offer my thanks too to Christian and Dr. Faiman for a fantastic presentation. We are right at the hour, and we do appreciate you sticking with us through this great content. This does conclude our Innovation in Hypertension series. My email is there on the screen. Certainly reach out if you have any questions. A recording and the supporting slides will be available in the coming days. We'll in fact share the recording of all 3 of our workshops so that we can continue the learning alongside you. For more information related to hypertension control and the American Heart Association's efforts, along with the American Medical Association, is our Target BP website, and that is www.targetbp.org. So I'd like to take this opportunity to thank quickly my partners, Missouri Department of Health and Human Services and Senior Services, excuse me, and the Health Innovation Quality Innovation Network for this great series together, and we look forward to offering more in the future. So with that, I wish you a great day, a great start to your summer, and stay tuned for more information and future workshops in the coming days. Thank you.
Thank you.
Great. Thank you very much, everybody.